Hello again, and welcome to the webinar on remote patient monitoring for pediatrics. We will begin at this time. Again, the webinar today will be recorded and provided to you as a follow-up so you can watch and share at your leisure. And we're very excited to be co-presenting Anytime Pediatrics and VitalFlo, again, remote patient monitoring for pediatrics. We have some industry leaders with us today, Dr. Jason Reynolds, who is a board-certified hospice and palliative medicine physician. He serves as the Associate Medical Director and Senior Consultant in Pediatric Palliative Care at Cook Children's Medical Center in Fort Worth, Texas. He also oversees there the virtual home-based care programs for children with complex needs. Luke Marshall is the founder and CEO of VitalFlo, a digital health company focused on remote patient monitoring and predictive analytics for chronic respiratory disease. He received his doctorate in material science and engineering from the University of Texas in Austin, where he began his focus on technology commercialization and development, helping get research off the bench into the real world as products and services. Dr. Mick Connors is the founder and CEO of Anytime Pediatrics, also an active emergency medicine physician. He is a serial entrepreneur, and we're very proud to have him co-presenting the webinar on behalf of Anytime Pediatrics today. And lastly, we'll be joined by Dr. Todd Rowland. He's a board-certified PM&R physician who has combined clinical work with medical informatics innovation for the past 25 years. He's completed medical informatics fellowship at Harvard, and he serves as a chief medical officer for VitalFlo Health. So without further ado, we will get started with Dr. Connors and talking about an overview of what remote patient monitoring in pediatrics means.
Thanks, Tencel, and thanks for the introductions, and appreciate Luke and Jason and Todd joining us today. You know, really the goal today, as we look at from the world of Anytime Pediatrics and from my world of how to get kids better care, is really trying to understand what's going on in technology and in innovation. So you may or may not have heard remote patient monitoring. You might have heard of RPM. We're excited to have VitalFlo kind of co-present this today. One, because, you know, just for clarity, we don't have any financial relationship or any conflict of interest. Really the goal in working with VitalFlo is one, a passion around pediatrics. They're very focused on pediatric asthma. So I'm a big supporter of anybody that's taking on the pediatric workflows and the challenges of pediatrics. And the second is they have a pretty cool device and a monitoring system that they've been using that's showing some promising results. So, you know, I think it'll be a really good discussion today. And really overall, that's what this is. I mean, what we're trying to do is educate pediatricians, pediatric practices, really everyone on exactly what is remote patient monitoring and what does it mean. You can go to the next slide. So when I think of remote patient monitoring, certainly before I began to get educated over the last several years of what it is, I kind of had this thought that it was just going to be an overwhelming stream of data that was going to be coming into my cell phone and texting me every 2 minutes. And really, what does it mean and what is it? So remote patient monitoring is a technology to enable monitoring of patients outside of a conventional clinical setting, such as in the home or in a remote area, which may increase access to care and decrease healthcare delivery costs. So the idea really is trying to add touch points, trying to identify when a patient is sick before they may even recognize that they're sick. It might be connecting with devices, you know, checking on someone daily, whether it's a glucometer, whether it's a pulse ox, whether it's something like that. So for the current definitions of RPM, it's not just texting, it's not just checking in on the patient, which I think is certainly a goal, and I think one that we should all be thinking about. But this is really about sensors on a device. It's about connecting those sensors back to some kind of centralized database and putting it into a data repository. So it's really gathering data, setting up parameters of when you or your nurse or your office want to get notified, or even more simply, it just gives you a dashboard so you can look at your patients and say, hey, you know, if they're an asthma patient, are they in the red zone today, the yellow zone, the green zone? So just a way to stay connected without picking up the phone, calling, filling out a piece of paper, you know, those kind of things. And at the end of the day, it is really using a diagnostic application to help route that patient or to identify what patients are worsening or having more difficulties or challenges. So, you know, at the end of the day, that's really what this is. It's remote patient monitoring. Is literally monitoring a patient remotely. Next slide. So I know when I first thought about this, and I sit in the ER now and I hear all the monitors going off and we all have alarm fatigue, was thinking, oh my gosh, this is going to be like the apnea monitor where patients are coming into the ER all the time, lugging in this 20-pound machine, saying that their child stopped breathing, and we're trying to get somebody to download it to see if that's true or not true. Really, you have to kind of put that out of your mind a little bit, because this is really a whole new evolution in technology where you can actually have real-time vital signs. You'll have the patient's record. I mean, with the smartphone technology, it'll be connected to their smartphone. Again, you can gather the data. It doesn't have to set off an alarm. It's not like I've fallen, I can't get up. These are really devices, whether it's from cardiology or asthma or obesity. These are devices that are connected into an app typically and gather data, and you can set the alarms and the alerts and the time of the day that you want to be alerted to it. So very different from the old apnea monitor and our worry about sensitivity and false alarms and those kind of things. This is really think about more longitudinal kind of data collection as opposed to, a trigger. Next slide. So I often think about this with telemedicine and technology, and I think about our old care continuum where mom's at home. She's thinking about, gosh, my kiddo's sick, and should I call the telephone triage? Maybe I should book an appointment with primary care. Gosh, primary care is not available. Should I go to urgent care? Maybe I'll just go to the emergency department and wind up being admitted to the hospital. Kind of these episodic, or what we even call in primary care, kind of that periodicity schedule, where you're going to come in once a year, going to get your annual checkup. You're going to get a pat on the back, and you're kind of going to go your way without really any other data points. Of course, at Anytime Pediatrics, our focus is on the medical home and how to keep them connected, because we know that, if we can kind of foster that continuum and keep primary care and those relationships at the center, that we can decrease hospitalizations, decrease ER visits, get less out-of-pocket spending, and kind of get lower per member per month costs. Really, this is about total cost of care. So when I look at the new paradigm in the next slide, Tencel, you almost think about a virtual care network continuum. So what we're talking about is real data that's continuous, that are touch points, that are not just that intermittent, gosh, mom's worried. It's trying to get that data ahead of knowing when a patient is worsening, or when there's a challenge, or when there's a problem, connecting that to primary care or routing that to after hours specialists. So I think as we look at data, and I know this scares a lot of people about technology, but whether it's telehealth, remote patient monitoring, asynchronous visits, anything you think about related to what we call virtual care, or in my estimation, it's really just the same old care delivered virtually. It's really going to be about data collection, data gathering. How do we use algorithms to get the patient to the right place at the right time with the right provider? So many people look at RPM, especially as kind of the fancy gadget on the shelf. That's kind of hey, this is super cool, and like Luke's a PhD and he went off and studied something cool and made a cool gadget. And, it's really about selling a gadget or doing things like that. But I think the more that you open your mind and kind of get into that growth mindset is maybe this can work. Maybe this can help. Maybe if I had a little more data on my patient ahead of time, they wouldn't wind up in the ER. They wouldn't wind up in the ICU. Next slide. So there's always a lot of pessimism around anything, right? So, and the data around RPM, I don't think has totally, solidified. It's all in the works. There's certainly good outcomes related to both neonatal. There's a lot of folks that are using it at neonatal, post-discharge and looking at patients that way. Diabetes has certainly shown some promise. I think Luke will talk a little bit about some of his promise related to asthma and identifying those patients before they even know they're kind of getting worse. So I think the data is coming. I think you'll see more of this, and it'll be less about kind of, hey, what's the coolest whiz bang thing I can attach to a patient? And it's really, what is the data that I need to identify, what my certain patient needs based on their condition, chronic condition, those kind of things. Next slide. Finally, again, it's a question of where is this? I think remote patient monitoring lags behind, the classic video visit. As we see virtual care evolving over the next months to years, I think remote patient monitoring will come along. It's still a challenge from a billing standpoint. There are codes. They are billed typically, especially under Medicare. The question is where they go in pediatrics. And unfortunately, like many things, pediatrics often lags behind. So, Right now, adults are the primary target for remote patient monitoring when you think about hypertension and chronic diabetes and avoiding readmissions as they put patients on a monitor for 30 days, all those kind of things. And the codes are there and they're coming. And in the adult world, they're getting paid. In the pediatric world, there are new codes in 2021. It's still gray. I wish insurance was straightforward, how exactly these codes will get billed, how much you'll get paid. What will be the incentive to stay connected to your patient on a more regular basis. So there are codes for setting up the patient, showing them how to use the device. There's codes for checking in every 30 days. There's codes that, if you check in every 7 days, typically it's time-based, and it doesn't necessarily have to be the physician. Often in the adult world, they use a medical assistant or a nurse to really track that data. So if you're in an asthma clinic and you have 100 asthmatics, you could sit down, each day or every other day to kind of look at their data, just in a typical dashboard to identify kind of what's going on. And as you do that over time, then you are able to bill for that time and be able to collect some remuneration for your time and to stay connected with the hope again of, gosh, maybe we can avoid an ICU stay or an ER visit or catch something more quickly before that child is out of medication and winds up in the ER on a continuous albuterol, or, we check on them every 6 months for their ADHD or their asthma or their obesity or mental health, things like that. So, again, I think about this a little less about the intimidating part of the technology and really how can we use it as a use case to stay more connected to our patients, foster those relationships, and identify kind of what's going on with them. Last slide. So I guess the question is still out there whether it'll become real for pediatrics. Many people question whether patients will use it. And Luke will talk a little bit about that. But, there's patient habits, there's physician habits. Where's the data flow? Does it come into the EMR? What's it do to our workflow? Are we going to get reimbursed? Are we going to get paid? Gosh, technology, so, all these things kind of are kind of the things that are driving telehealth right now and video visits and really pushing things forward. But then, of course, there's the uncertainties, and especially in pediatrics, it's, hey, what is the payment? Does this really work? I had somebody mention that maybe this is a scam and this is a way just to kind of bill patients for more use of technology, which, again, I hope any technology is really about connecting relationships, identifying, key metrics that we want to follow, and really see if we can make this sustainable and identify a sustainable business model so patients get better care, they stay connected to relationships, and in the end of the day, we're kind of able to add value and lower that total cost of care. So this is by no means a slam dunk from that standpoint, especially in pediatrics. There's still much work to do, but thankfully there's folks that are interested in this and that are kind of on the leading edge of remote patient monitoring in pediatrics and see the value add. So with that, that's kind of the overview of what remote patient monitoring is, where we see the opportunities, and where I think I see the value, and what gets me excited about it is anything that can keep us connected to those established relationships, especially in pediatrics, I think is incredibly important. All right, so without further ado, we'll really turn this into questions, and you certainly are welcome in the chat to ask questions. Tencel will keep track of those for us. But I think part of this is really fostering a discussion. So it's my great pleasure to introduce Dr. Jason Reynolds, who's, as Tencel introduced, is working in hospice and palliative care. But he's somebody that I've known for a long period of time, who's just the consummate pediatrician who now works in an area that's very challenging with complex chronic patients, with patients that really need to stay at home or be at home, and how they can really stay connected to him. He now covers a wide variety of geography across the state of Texas with, some of the most complex patients. So he's in the learning stages, as we all are, of, gosh, could RPM help, and how could it help? So Jason, thanks for joining us today.
Yeah, thanks, Mick.
So Jason, can you tell us a little bit about your practice? First of all, what is a day-to-day practice in hospice and palliative care for someone like Dr. Reynolds down at Cook Children's?
Well, thanks for your kind words. First of all, Mick, it's a joy to be here and chat with you guys. I'll just tell you a little bit about my practice and what we see as the direction of healthcare as it relates to caring for children with complex needs. I would say over the course of the last 3 years, we've really been focused on building our telehealth or telemedicine technology, because the patients that we care for generally have a lot of technology needs. It's not easy for them to access the medical system. And at times, because they're chronically ill, accessing the medical system can actually be a bit dangerous for them. Many of them are on respiratory support, trying to cart their technologies into some sort of vehicle or transport device, and then come into a clinic and sit in a waiting room full of sick kids can actually be a bit of a burden or a danger for them. And so we spent the better part of the last 2 or 3 years trying to get in the home. And Texas is really very favorable from a payer standpoint over the course of the last 18 months or so, as far as being able to bill and get reimbursement for video visits in the home as a location. We expected that as we rolled these programs out, the patients would gradually prefer this modality of care. We expected it to sort of be a slow uptick, and we never could have imagined this whole COVID situation, how it's changed the way we deliver care. But because we were poised to deliver care from a virtual standpoint, we're really about the only practice in the entire medical center that's had explosive growth over the last 12 months in the COVID era, the pandemic era, because we're able to easily get in the home and deliver care in the home. My practice now is, my outpatient practice anyway, is almost 100% virtual care. It's very rare that anyone comes into the office to see me. Now, my practice is a little unique in that mostly I just talk with families and help them sort through what's going on. They have a lot of technology in the house that I can, get appropriate vital signs and whatnot from. But it really lends itself to care in the home. What we found is that patients spend 30 minutes to an hour accessing the medical system now, as opposed to 6 or 8 hours trying to access the medical system. And we're also, we don't have the data for it. We're also seeing that our kids end up in the ICU quite a bit less frequently, because they're not exposed to the rhinovirus or the flu or the whatever they get when they try to access the medical system in the community. So I would say, from a telemedicine standpoint, getting into the home virtual care, our program is very successful, and our patients are very happy with it. We do have some preliminary data that the total cost of care has been driven down. But there's still a huge opportunity, and that's really what we're trying to sort through now, both from a quality of care standpoint and also from the standpoint of trying to build our own practice and stay up with the technology, stay relevant. And the truth of the matter is, there's a lot of competition in the market. And if we ever get sort of the breaking down of state barriers to deliver healthcare, there's going to be even more competition. So how do we stay relevant while providing, top quality care? And really, remote patient monitoring is the big gap that we see, because we still have patients that they don't access the system until they're in extremis. And there's a number of different conditions that you can imagine. Respiratory is a big one. Sure would be nice if we could keep an eye on what's going on with their oxygen requirement. We just put a Bluetooth device on an oxygen flow meter, so that we know they go from 0.1 to 0.5 to 1 to 4 liters of oxygen. That would be relevant information for us to know. And for whatever reason, no matter how many times we tell the parents to call us, on Saturday night at 2 a.m., they don't pick up the phone. They wait till they're in extremis, on Monday morning, and then they end up in an ambulance in the ER. And not only is the total cost of care driven up by that, the opportunity to intervene at an earlier stage is also oftentimes lost. But there's respiratory conditions. Pain is something we deal with a lot. Oftentimes patients will wait till they're in a pain crisis. And then it's so much harder to get their pain under control. Oftentimes it requires an ER visit and a hospitalization, as opposed to being able to intervene at a much earlier point in time. We care for a lot of oncology patients that we sure would like to know as soon as they have a fever, as soon as they cross the 38 or 30 or 100.4 or whatever the mark is, if we could know about that in real time, we could intervene right away and get them to come in and get their workup and start some antibiotics, as opposed to waiting for them. Again, Saturday at 2 a.m., they're just reluctant to call instead of waiting for them to develop other symptoms and then end up in the ER or in the hospital with a situation that's more progressed and difficult to treat. So we feel like there's a huge opportunity to improve the quality of care that we provide, especially for complex pediatric patients at home, to lower the barriers to access, because that's really the biggest problem that we see is there's still a barrier to access. And if we could get data in real time that doesn't require a mom or a dad or a caregiver at home to try and be the nurse or the physician to try to know exactly when they should access care. If we could help them understand when to access care, or even reach out to them when it seems appropriate to access care, we really think we could drive down the total cost of care and increase the quality of care that we provide. But the other aspect of it is just from a personal practice standpoint. It's sort of a win-win-win with all these technologies, because by driving down the total cost of care, by getting these devices in the home, we're also increasing our footprint in the care of these patients, if you will. We're driving more visits into our outpatient practice and away from the ER. And that's just a win-win-win for the patient, for us, for the payers. That's really what we're looking for. So there's a lot of opportunity in this remote patient monitoring space. We're still trying to figure it out, but Mick has been a real help, and I'm really interested to hear more about what Luke and Todd are doing.
Yeah, Jason, that's great. That's a great overview. I mean, I think the other thing that's, when I think about talking with you about hospice and complex chronic care, I witness an ICU at home where you have 10 monitors on a patient, right? And you're monitoring, G-tube pressure to, trach. And when I talk to you, it's really so much less than that. I mean, all you really want is a daily kind of almost a text message, right? Yeah, it'd be nice to have some of these RPM, some of these technologies, but tell us a little bit about your experience, especially with these very chronic kids, and just that daily check-in, even if it's just an automated text, or what you want to know and what you think moves the needle, right? Is it going from 0.1 liter to 0.5 liter, or is it somebody just saying, hey, I'm in trouble?
Right. Yeah. So we're like many others. We're trying to figure out how to deliver great care, but also develop an economic model that's sustainable. We can only do so much for free. And so really what we want to know is just exactly what Mick said. Probably the most effective thing is to drop a text message and say, hey, how's it going today? Good, bad, or same as yesterday? And that's enormous. That's an enormous amount of very useful information. And I got the COVID vaccine, and I get the text message from the CDC each day. And it's very, very useful, because if I've got 100 patients that I'm trying to care for, all of who have complex needs, I can see the 4 patients that are having a bad day, or the 2 patients that have had 3 bad days in a row. And historically, what we do is we just hope that those people that are having bad days will pick up the phone and call us. But no matter how much we break down the system and try to make it easy, for whatever reason, there's just barriers. And so I can easily, or somebody in my office can easily identify the 4 patients or the 2 patients that are maybe at risk for having some problems. And so, and we've talked about ways to, get a little bit more granular. If somebody's having a bad day, we could ask them, well, are you having pain or trouble breathing? And if they click yes to that, then they could tell us a little bit more. So there's a lot of different ways to really quite easily break down a logic in a system that would give us a ton of information. It would take about, probably somewhere between 10 and 30 seconds for the family. It doesn't require a sophisticated, $20,000 computer, in there. Just a basic smartphone that can get text messages is really about all it requires. And so that's really what we're working on right now. We've rolled out some early versions of this sort of remote symptom management tool. The problem is you can't get paid for a remote symptom management tool at the moment. And so the question is, is there something that we can add to this system that is not just gaming the system, but would provide us with useful information that would elevate the care that we're already providing to that which qualifies as remote patient monitoring. And as Mick had mentioned, we're trying to sort out exactly what data we want. I mean, it would be super helpful to have somebody's pulse oximetry readings. Do I want those continuously for 24 hours? Do I want a spot check every 6 hours? You know, how do I verify that the probe is on and it's actually a good reading? And so we're trying to sort through some of those things now. But I feel like getting this technology into the house, trying to troubleshoot it, trying to figure out what works and what doesn't work, and trying to show ultimately that we reduce the total cost of care by improving the quality of care is really the goal here. And it sounds like Luke and Todd have already crossed that bridge in some respects.
One last question for you, Jason. You've talked a lot about how this impacts you, and I know you're at the anecdotal stage. Can you tell us a story about how it impacts your patients and their quality of life, and how you see that on the, you know, from these folks? I mean, as an ER doc, I mean, the minute one of these kids that comes in with multiple complex chronic diseases, I get them to the ICU as quick as I can.
Yeah.
So how does it impact the families, you know, as far as being able to stay home, manage those things, not load up the ambulance or the truck with every single device?
No, that's a great question, Mick. You know, we have, like you said, it's sort of anecdotal, but we have a couple of patients that we've actually looked at the total cost of care and how they access care, because even total cost of care is a little bit hard to sort out with medically complex patients that are getting progressively worse, you know, month after month and year after year. But some of the patients we've looked at, well, I can talk about two patients in particular, two patients that we sent home, enrolled with hospice, true hospice plan of care, not anticipating to come back to the hospital, and expected to progress to end of life and, you know, in the next, you know, several months. Both of those patients are, you know, this was 2 years ago that we enrolled those patients. Both of those patients have been unenrolled from hospice. Only one hospitalization between the two of those patients in the last 2 years versus, you know, 3 or 4 in the years prior to that. Most of those ICU admissions, multiple ER visits, multiple, you know, in-person physician visits, and their whole medical care for the most part has been converted to a virtual in-home based care. And they're doing well. And one of them in particular is doing much better than she was, you know, in the years prior to us getting involved. But the one patient that did get admitted is really sort of a case example for RPM. This was the classic, you know, patient we see every couple of weeks. We talk about the plan, we talk about what we'd be worried about, you know, and on Saturday night, the oxygen requirement was going up. The patient was developing more respiratory distress, a number of symptoms that would be obvious to us as problematic, and we didn't get notified, you know, until, you know, 8 a.m. or 7:30 a.m. on Monday morning, and then trying to activate the system at that point, we were just too far behind the 8 ball, and the family was sort of panicked and called 911, and the ambulance picked the patient up from ER, you know, a 10-day ICU stay, and amazingly we were able to get the patient back home. But if we'd had RPM in that setting, we would have known there was a problem on Sunday morning probably, and we could have reached out to the patient or the family or the caregivers and tried to see what we could do at home to intervene in a much earlier place. And to be honest with you, accessing the medical system sometimes is, like you said, Mick, is not the best thing for the patient. You know, EMS drivers and emergency departments, particularly if they're not accustomed to caring for pediatric patients, can sometimes do more harm than good for some of these complex patients. So.
All right, Jason, that's great. We'll let you get off the hot seat now.
Thanks, Mick.
But stick around, you're getting some questions.
Yes.
So we'll shift over to Dr. Rowland. So Dr. Rowland is kind of a triple threat in many ways, right? So he's a physician, he's an innovator, he is an adult physical medicine and rehabilitation physician. So he's been using RPM, I think, for a while and using it successfully in his practice. So Todd, it's a pleasure to have you on Great to hear your perspective from how you use RPM, how you see the future of RPM, and why you've become involved with VitalFlo. I think you're on mute, Todd. Can't have a good Zoom call without that being stated at least once, right?
Can you hear me now?
Yeah, yes. The Horizon is working. Oh, now we lost you.
Is that better now?
Yeah, that's better.
Can you guys hear me?
Yes.
Okay, sorry about that. All right, I'm having all kinds of really fun technical challenges today. So why not, right? So excited to be here, and I really enjoyed the dialogue between you and Mick and Jason in talking about the complex care. My background in medical informatics and rehab has really been a career that's been really involved with a lot of complicated patients. As a rehab doc, we take care of really some of the most complicated patients in the adult world that are around. And we try to do as much care coordination, care navigation, and other things as we can. Historically, a lot of us have not used remote care, telemedicine for various reasons. I think it's probably been a combination of both patient preference and payment and other barriers. Obviously, with COVID, that's all changed for now, and so we've all seen a dramatic change. In my clinical practice, we're using telemedicine in nursing homes for rehabilitation patients, and we don't in our field we don't happen to have a great RPM activity, but really in contrast to that, the work I've done as the chief medical officer with VitalFlo has been awesome in terms of having the capacity to do integrate RPM into virtual care. So what I would just say from a business model to begin with is, if you don't have RPM, it's going to be really hard to make a great business case for telemedicine on an ongoing basis. And the biggest benefit, just from a purely kind of operational financial perspective, is that it's a non-physician revenue generator for your office, which for the adults, we've been doing that with CCM, chronic care management, for several years with Medicare. I don't believe the pediatricians have had the opportunity to take that journey, but it definitely has generated a lot more income into kind of the fragile primary care business model. So the thing about what's interesting to me with our clients that we're seeing with VitalFlo is we've got a dashboard that looks at this patient panel, and we get a red, yellow, green kind of thing. And so we know, who's doing well, who's not doing well. And a lot of that work can be delegated until it needs to be escalated to the physician. So, Mick, one of the things you were saying is, I think physicians are always worried about, I've already got so many interruptions, I've got so many things going on. How can I possibly have another channel? And the thing about RPM, the way we do it, is we don't interrupt the physicians, we don't bother them. We use non-physician workforce to monitor that patient panel, and then escalate only when needed, within a protocol. So that's been something that's been very favorable both at Duke and UNC. And I know that Luke will be able to share, many of the anecdotes about our asthma patients that have realized they're deteriorating because of the spirometry readings, and they really didn't understand that they were deteriorating, just as evidenced by their objective measures like the symptom survey. So I'm going to pause for a second there.
Yeah. So Todd, in your experience, kind of in the adult world or looking at RPM, how would you say overall? Certainly, revenue is important, but always to pediatricians, it's outcomes, right? So, have you been able to witness some change in outcomes, keeping patients in nursing homes, keeping them at home, from the value of RPM attached to telemedicine or a video visit, or what do you think the overall impact will be of RPM kind of going forward?
Yeah, RPM is still a relatively new thing, right? And so I would tell you that the prior experience with adult medicine with what's called TCM and CCM coding, which pays us to do additional work at transitions in care and for high-risk patients, has been incredibly successful. In that we've it's really been the only hospital readmission work that's actually worked. And you're getting warm phone calls from your primary care doc because they know where you are. You know, you're in the hospital, you're transitioned back to home. And many times adult primary care docs don't know that. So the analogous thing in the future is this RPM, where you have at least 16 days out of the month, you're going to have information about how that patient and that family is doing. And the nature of RPM, there's multiple RPM codes that can be done from cardiology to spirometry to oximetry. So you have information that essentially can trigger concern. So we can status with VitalFlo a patient going from green to yellow to red, and then that can allow us to escalate. And it also allows a non-physician staff member to understand, oh, this person's getting worse. I need to do something about it. So what it really does is it results in outreach. So just like Jason was saying, of your panel of patients, you know which patients need the outreach. You know who needs that phone call to have a conversation about what's going on. And the intention with that is to prevent, especially the unnecessary emergency care that so frequently happens with asthma patients, because they just don't know until maybe 20, 30 minutes ahead that they're actually, really declining. So our spirometry measurement has given the clinicians much more information earlier about that. So what I did there is kind of combine some information and experience from the adult primary care world that we had with care management, and then really segue that into the early work that we're doing with RPM. RPM is still kind of an area that a lot of clinicians don't know about. And so I think we're going to have to figure out what the right level of alerting and escalation and things like that are. And there's certainly active work going on, especially now that the insurance companies are taking it seriously.
And Todd, I guess from an asthma perspective, I can ask Luke this as well, but I was always interested in, and when I was at Connecticut Children's, they had a severe asthma clinic, and they also had a program that I believe it was called Breathe Easy program, where the patient would document on a piece of paper kind of what's been going on the last 30 days, ask them kind of that asthma control questionnaire, bring it into the clinic. Interestingly enough, the severe asthma clinic had a show rate of about 20%, for those patients to actually come to clinic. I mean, do you think if they're non-compliant with coming to clinic, will they be more compliant with being able to identify? I mean, obviously it's a low bar to jump to get above 20%, because they would often find their patients in the ER or, those kind of things, or lacking transportation to get to the clinic. How do you see RPM impacting that for, the underserved population, the Medicaid population, the
Right.
population that's really kind of falls in that severe asthma category? That, will they do this, and will it help?
Yeah, I mean, I think our results so far suggest absolutely, much more so than a 80% people not showing up. We're much better than that. One of the things that when we've had discussions with our teams is that we've gotten teenagers at Duke and UNC to actually use spirometry effectively up to 2 times per day. So as a parent of a teenager, can you really imagine your kid being that compliant? So, when you have that kind of measurement and engagement with the smartphone technology, it's just a totally different experience than trying to have people come over who don't maybe have the greatest transportation options getting in there. We're also finding that, groups that are low socioeconomic have smartphones, and they do have enough of a data plan to make this work. So that has not been nearly the barrier that you might think it would be. There's certainly a lot of evidence that the Medicaid population has done well with mobile technology, because that people are often prioritizing their cell phone over any other bill payment, maybe even food sometimes. So yeah, we're way above a 20% show rate. And I know Luke can speak to that in a lot more detail.
Yeah. Thanks, Todd. Yeah, Luke, we'll turn it over to you. So I guess the first thing is a PhD. How do you go from a PhD to really wanting to solve pediatric asthma? I love stories, so I'm curious. you could share with us your story of how you wound up in the field of pediatric asthma and trying to make your impact there.
Yeah, thanks. The my journey has definitely been a little bit of I kind of came into this field horizontally. I mean, I grew up in a household where my dad was an emergency medicine physician, so I at least had some exposure to the world of healthcare. But when I was doing my PhD, it was in material science. I was working with the inventor of the lithium-ion battery, who he just got his Nobel for that a couple of years ago, and doing very kind of on the ground. What do we make stuff out of? What do we make batteries out of? What do we make hard drives out of? Looking at that kind of at the atomic level. So that's not healthcare, right? But what I fell in love with during that process wasn't the nitty gritty of the physics or the nitty gritty of the engineering. It was, how does this get off the bench, right? So it's like lithium ion batteries are great, but they're great because they're in your cell phone and because we can make them at scale. And now that introduced this whole wireless revolution, right? So what's the equivalent change that these technologies can make? So I got really into technology commercialization and what is the path from the bench to products and services where it really makes a difference. And I ended up following my wife from, we were in Boston down to the Research Triangle and looking for some technologies that were really interesting. And VitalFlo was born in clinical research at UNC School of Medicine and NC State University. So nice collaboration of clinical research and engineering expertise. And basically, Dr. Dave Peden and Dr. Michelle Hernandez, who are respectively the former president and a fellow of the American Academy of Allergy, Asthma, and Immunology, basically pitched this idea to a bunch of geeks of, hey, we could really use this tool for both our research and for our clinical practice to see how patients are doing at home. And basically, can we miniaturize this procedure that used to be a desktop unit for spirometry? Can we put that in somebody's hand, connect it to a smartphone, send it home? That started almost 10 years ago now, that research project. I got involved to help pull it out of that university ecosystem and get it into the world, because that's kind of where my head likes to work. But I've also had this research exposure, and it's really in that translation. And with healthcare, you really don't want to just be some kind of like tech first type of entity. You really want to have everything based in clinical validation, clinical research, and make sure this stuff actually works. And that's really been our focus. That's been built into the DNA of the team because of this history of pulling it out of these research institutions. And that's actually still a line of business for us, is to continue to be a product that helps now research studies convert to fully virtual. In a post-COVID world where your respiratory study has been put on pause because in-clinic spirometry is now considered a risky procedure, because go figure, you're going to aerosolize everything in your lungs if you blow hard through a tube. Being able to perform that and get clinical quality data at home is really valuable for researchers. It's also, obviously, as we've been talking about, valuable for practitioners. And one of the things that we've been interested in is making sure we have clinically valid solutions that are easy to interpret at a variety of levels of expertise and specialization. We really see kind of the primary care providers as the quarterbacks of care, and sometimes that we need to refer out to specialists, but a lot of times, like, that's home base, right? So that's where the relationship is, that's where the trust is. How do we extend the ability of the primary care physician or the pediatrician to do some of these more specialist procedures, understand them intuitively, and what can we do as a product and technology team to kind of simplify that and make that easy to access? So there's always more layers of data you can dig into, but that first pass is, yeah, this patient's in trouble, I need to talk to him. And that's kind of a little bit of the story of how we got there, and now I'm starting to talk about the product because it just gets me excited to help out, but I'll pause there.
Yeah, no, that's great. I mean, I think, it's certainly fascinating to see how we can make things that are clinically relevant, not just, cool tech whiz bang kind of thing. So can you tell folks in a brief synopsis, what is VitalFlo, what it does? I mean, kind of, you have two components, really a third optional component, but primarily kind of a questionnaire and inspirometer. You want to just talk a little bit high level?
Yeah, sure. So we are a remote respiratory monitoring company. So we're very focused on that vertical and focusing on chronic respiratory disease primarily. We basically, from the patient experience side, like you said, there's kind of two main products that we integrate with. We have a mobile spirometer that connects to a VitalFlo app on their smartphone via Bluetooth. And in that app, we also have a symptom survey. So I think it was Dr. Reynolds that referenced the ACT, which is kind of that classic 30-day retrospective survey where you're basically counting on patients to remember how they were feeling a month ago as part of answering that question. The ACT is actually a really good survey because it's been validated and shown to correlate with next day control of asthma. So it's actually a really useful tool, even though the data is kind of in data science land, what we'd call pretty fuzzy. So what we've done is taken a similar set of symptom questions, but we ask that survey every single day. And we've actually recently shown that it is as predictive of next day control as the ACT itself. But we have a much more structured data set as a result, which again, this might be getting a little geeky in the data science land, but it's much more, because we're talking about the last 24 hours, we know that the accuracy of any given data point that the patient's providing is higher. So that allows us to look at the gaps in between the data and have a better understanding of what's going on because it's less fuzzy in that sense. So we have this spirometry product, we have this symptom survey product. We also integrate with a few other things that can affect respiratory disease, especially looking at air quality. So we do have an optional indoor air quality monitor. We look at some we pull in some outdoor air quality information around pollen or particulate in the air, and use all that to drive clinical decision support and data transfer back to the clinical team. You know, part of what we're doing is just taking data from the home and putting it back in front of the doctor and the clinical team. But we're also using analytics to simplify all that and make it easy to interpret, as well as eventually start to forecast outcomes in terms of how's this patient doing right now, but also how are they going to be doing tomorrow, the next day, a week from now. And one of the things that we look at is how do we take all these patients. So if you have 200 asthmatics in your patient population, previous versions of analytics that are in theory called predictive might instead just be kind of risk stratification tools. So here's the high risk patients that generally end up in the ER more often, and here's the low risk, generally healthier patients. But we see that as kind of a good first step, but not the whole story. Because as the clinical team and the provider, what you really care about is who's the 10% of my population that's at risk this week, not just in general. So we're trying to answer that type of question around when is this patient going to be in trouble and what can I do about it?
Right. And you do have some data you want to share, or I mean, I think you have a little more even than anecdotal, right? You've been at this for a little while, so you want to just highlight the high points?
Yeah, so Dr. Roland alluded to it a little bit, but in our kind of foundational clinical study with UNC School of Medicine, one of the things that we have looked at a lot is adherence, because obviously if you're not using the tool, we're not going to get that data back for the clinical team to make some interventions. But what we've seen is during that study, which is a 43 patient study where every patient took the system home for 6 months, we saw throughout that 6-month period, 60% at least one time daily use. So 60% of days on average, the patient would use the device at least once, and 50% of days, the patient would use the device at least twice. As Dr. Roland mentioned, that's better than the 20% that you might see kind of in standard clinical practice, which is great. Anecdotally, what we've also seen with some of our early provider customers are these quick use cases for intervention. So we have, as an example, we went live with a primary care provider who's recently started to work in telehealth. And within a week of going live with VitalFlo with one of their patients, what they noticed was a discrepancy between the self-reported symptoms and the patient's spirometry. And this was a 14-year-old pediatric patient. And what I'll note is this is probably something that y'all have all seen many times, is the adolescents adolescent pediatric patients very frequently have poor symptom self-perception. So you ask them how they're doing, they're going to say, I feel fine. Some of that is teenage invincibility. Some of that is just not understanding, this is what not fine feels like. And so that created this moment where, so for example, on our dashboard, the symptom survey was saying, it's all green lights. The spirometry was saying, no, this patient needs to be looked at. And that allowed the PA to basically reach out and say, hey, what's actually going on? Learn from the patient's mother that she had been coughing during the night, and was also about to start kind of the winter sports season, which because of COVID this year was outside. So cold weather can also be a trigger for asthma attacks. And all that led to exactly what we would hope it would, which is an adjustment of their medication therapy and calming down of these issues. So it's a really interesting place that we can play to deliver data that doctors already know how to use in terms of a pulmonary function test, getting the high level metrics out of that, like FEV1. We can also show changes over time in this data, which then you can start to catch downward trends a little bit earlier. But also because we're collecting both the objective true north spirometry, how your lungs doing today data, and the subjective symptom survey data, we know that those don't always line up because people are human and they don't necessarily perfectly perceive how they're doing. So it can also be these moments for education and for outreach that ultimately drive better long-term outcomes.
Yeah, that's great. Appreciate you sharing that. So there's one of the questions early on is, and Jason or Luke, I mean, how do you know that the patient is actually using the device correctly? Is it something that you're going to get on video with a nurse to go through it to kind of understand, or are you worried that, Jason, like when they do the pulse ox, that, it's going to be a false reading or a bad reading or something like that? How are you going to manage kind of the false alarms? We'll start with you, Jason.
I think that's a great question, Mick, and I think that's part of why we need to deploy some of these things into the home to see how functional they are and understand the obstacles. And so at least our initial plan is to utilize those with patients. Many of our patients have some degree of skilled nursing at home, whether it's a hospice nurse visiting or it's full-time, daily skilled nurses in the house. So that's the way we intend to initially at least validate some of the data that we're receiving, and try to do it in a spot manner where we would spot check vitals as opposed to put on a pulse ox and have it run continuously 24 hours a day. But I think there's going to be a lot of troubleshooting and trial and error in the coming months or years as we try to not just deploy this technology into the home, but make sure that the data that we're receiving is in fact accurate. And if it is accurate, is that data even useful to impact the quality of care?
And Luke, how do you monitor that they're using the, getting the FEV1 and, doing it appropriately, kind of using the inspirometer?
Yeah, that's a really good question, especially with spirometry. It's usually a coached procedure, right? Where you have, in clinic, you'd have the nurse or the respiratory therapist sitting next to the patient, encouraging them to, keep going, to get that full 6-second exhale, depending on their age. We build most of that coaching into the app, and we have some analytics that live in the app to basically validate each effort. So when, for a clinically valid spirometry session, just to get a little bit in the weeds, what you want is 3 valid blows, valid expiratory curves that are within about 5% of each other, and you take the best one as your diagnostic kind of true north. Sometimes you don't get 3 for 3. Sometimes you need a couple extra efforts because you might cough in the middle of one of those efforts. You might end too soon in one of the middle of those efforts. And those are things that we can automatically detect as the patient is performing and notify them, like, this one didn't work because you coughed. Try to avoid coughing on the next one. And that's all built into the ecosystem and the app.
So what do you think is the realistic age that you have been successful with inspirometry? Like in the office, some folks are, one question is about kids under 6 have a really hard time. Like, is there an age limit that you have found, or is it still in the works?
Yeah, that's a really good question. My the first off the cuff answer is we view that as a clinical decision. one of our partners, so we don't make our own hardware for this. We partner with these mobile devices and these mobile spirometers, and we make sure that we're validating the data that's coming off of those devices. So we're really this software layer that sits in between, and we view our job as making sure that everything that's coming off is valid. The manufacturer of the device is technically cleared by the FDA down to the age of 3. Now, anybody who's in pediatrics probably is in my camp on this, that's probably a pretty tough sell to get good spirometry from a 3-year-old. I don't think that's going to be too controversial. What we've seen in our system is generally when the kids start to hit double digits, that's the best fit. So kind of double digits and older. We've seen successful efforts with 8-year-olds. It gets, the younger you go, the more you want a little bit more of that in-person coaching. So it really kind of depends on the kid and the maturity level and how well they kind of take some of that feedback. But what we've seen, our best success is with double digits. The UNC study that I referenced was ages 12 to 20, and we saw really excellent quality spirometry through that. So some of it'll be kind of the lower bound will be clinician choice, but I would be hesitant to recommend going any younger than 8. And as a general rule, I think 10-year-olds and above is a good rule of thumb.
Yeah, have you ever used it to diagnose someone with asthma that didn't have it? Ever using it as an FEV1 from that perspective, or is it simply for kids that have been diagnosed prior? Is another question.
That's a good question. We have not used it more broadly than folks with chronic respiratory disease. Some of that is related to the company mission. But we have started to explore, mostly on the research side, so less in live clinical practice. But there's obviously other conditions where monitoring FEV1 and spirometry are very interesting. So we like to engage with additional conditions in the context of research to make sure that anything that we release into the wild is validated first. But in principle, I mean, it's a mobile spirometer, so you could use it for anything where that is a metric that you want to get for your patient. We've designed most of our surveys and all that kind of stuff around asthma specifically. Our next step is likely going to be into COPD, which obviously is not necessarily a pediatric condition. But chronic respiratory is our true north, but it's still a spirometer, so you can use it for any patient that would be interested there. The use case question is one that's interesting, because do you need to monitor a non-chronic respiratory disease patient if they don't have asthma? Do you need to monitor them on an ongoing basis for that? Because what the tool is, the best use for the tool is if you want to look at how people are trending over time, as opposed to the one data point. Because if it's the one data point, you can probably get that in the office.
All right, great. We'll just want to, I mean, we're up on the hour, so I know folks are busy and have other things. So I want to thank Dr. Reynolds, Dr. Marshall, and Dr. Rowland for sharing their insights on remote patient monitoring. Obviously, this is the beginning of a discussion, certainly, not the end. There's a lot more to come. I mean, I think I'm hopeful that it will help kind of lower total cost of care, improve, care for kids. And so I think there's a lot more to come, and really appreciate you guys sharing your experience and your insights. Tencel, I'll turn it back over to you. I didn't know if you were going to, and thank everyone for the questions. Appreciate it.
Absolutely. And you may have already touched on this, but does VitalFlo integrate with the EHR systems at all?
We definitely can. We designed the system, and this is part of why Dr. Rowland's on the team with his background in data interoperability and health informatics. So we can. Generally, what we do is roll out in our first phase of an implementation with the provider is set them up in our dashboard, get to learn their workflow, and make sure that when we do the deeper integration with the EHR, that everything fits. But it's designed to integrate with to EHRs.
Wonderful. And yeah, one other comment came in, maybe using an incentive as featuring the use of the spirometry as a game will help drive better results in pediatrics specifically. So great feedback there. Thank you all so much for your questions today. Again, you'll receive a link to this recording. Thank you to our panelists, Dr. Reynolds, Luke, Dr. Connors, and Dr. Rowland as well. Hope you all have a great afternoon.